Hello. Hello, everybody. Good evening. We have this international 6th International Cardiology CME beginning now. And the panel that we have is very renowned. Almost everyone is a world leader in the field of interventional cardiology, global leader. And the topic is also very important, Lmca Pci intricacies. And there are several things which have happened over a period of time. There are several things have come in perspective to check whether what we have is right or wrong. And I would like to share my screen. Share my screen. And so we all know that the left main coronary artery disease, predominantly it is distal. Almost 3/4 cases are distal due to the flow dynamics at the carina. Carina behaves like a flow diverter and bears the maximum wall shear stress, and that is a proatherogenic if it is oscillatory. 50% of the artery, if Lmca is blocked, 1-year mortality is 20%, and it becomes 50% at 3 years. There's a new subset of Lmca disease has been identified in the ischemia trial sub-analysis by CTA, that intermediate lesion, that is 25 to 49%, they too have an increased risk of primary endpoints like cardiovascular death, MI, resuscitated cardiac arrest, hospitalization for unstable angina, but statistically not significant. But we need to look at this subset now separately. And we have Dr. Sunil Rao talking on it, who will enlighten us on how to evaluate the intermediate subset. Now, coming to the risk evaluation in the Lmca Pci, the syntax score has been very useful in defining the risk. We know that it is divided into low, intermediate, and high syntax score. When high syntax score is there, obviously the distal left main involvement is almost 3/4. The higher the intermediate, higher the syntax score, the cumulative MACE rate is also higher over a period of 10 years. So we should keep that in mind. Plus now syntax 2 score is also added. Now looking at the strategy, the stenting strategy or PCI strategy, provisional 50% and 2 stent 50%. Because in the other epicardial artery other than the left main, the situation is a little different. Maybe 70–80% is provisional and about 20%, because the major side branch as circumflex arises from the left main, and out of the provisional, 30% almost converted to 2-stent strategy. Now, physiology has become a gold standard. Physiology become an absolute gold standard. Various ways we can do a physiologic evaluation: hyperemic, sub-max hyperemic, on non-hyperemic. We use whole cardiac cycle or diastolic or sub-cycle. Dr. Sunil Rao will enlighten us on this. Now, there are several challenges. One is the angle. We all know that distal angle is already in the perspective of the interventional cardiologists where they consider two stent strategy, which is complex PCI. But single crossover strategy is now a common phenomenon, especially when the lesion, Medina lesion is 0-1-0, that is LAD ostial lesion. This angle, main vessel angle, is not put into perspective, though there is a study which is done and we showed that if the angle is high, then the event-free survival rate is high. If angle is low, event-free survival rate is low, and which is statistically significant with a p-value of 0.18. And this is the case example where one side angle is a single crossover stent, the main vessel angle high, so no restenosis because there is no oscillatory shear stress when angle is high. When angle is low, oscillatory shear stress, which is pro-atherogenic, becomes more when the angle is narrow, and this we need to put in perspective. We'll ask our expert their comments on this. Then second challenge after the angle is the calcium. And when calcification and the bifurcation, they're associated together, it becomes a bigger challenge. And a study done in this, evaluating 21,000 of rotor cases done at Mount Sinai, revealed that when both together, bifurcation, Nepen bifurcation, and the calcium, severe calcium, both are associated together, cardiac death, stent thrombosis, MI, all are significantly higher, and p-values suggest they are significantly higher. And based on the OCT analysis for the calcium, the score has been defined. If the calcium thickness is more than 0.5 millimeter, if the calcium length, calcification length is more than 5 millimeter, and the arc of the calcium more than 180 degree. That's when the under expansion of the stent happens quite significantly. Almost 30% stent remains under expanded, and with only thickness it is 10%. With only significant length it is 7.5%. But arc of calcium more than 180 degree, it's whopping 30%. So arc of calcium is the sum which has a limitation in outcome of the Lmca Pci. Now coming to the calcium, which is heavy and sitting in the deep in the coronary artery, rota has a limitation that wire bias in the rota does not remove complete arc of calcium. That's where stent gets malopposed or under expanded and leads to stent failure. So do we need to add lithotripsy to take care of the remaining calcium, or in a patient who's got a very critical lesion, the IVL balloon cannot cross that lesion, then consider using the rota first and then do a lithoplasty also to cut the deeper calcium or remaining arc of the calcium. Maybe that will give better result, but studies we required in that respect. Already, I think there is a shock trial which is going on. Let's see the results of shock trial, which is already on. Now, there is a simple algorithm which is set up with so many atherectomy tools have coming up. It suggests that if you have a balloon crossable lesion, then pre-dilate, do intravascular imaging, assess the score of the calcium. It is fulfilling the criteria of 180 degree arc, more than 5 millimeter length and 0.5 millimeter thickness, and calcium is deep, then directly consider lithoplasty. If it is not deep sitting calcium, then we can consider rota or orbital atherectomy and see if the balloon is expanding optimally or not. If balloon not expanded optically, again we can consider lithoplasty, then stenting and intravascular imaging to decide whether stent is properly apposed and not under expanded, and to give a long-term good result. This is a very important territory because this alone supplies 75% area of the left ventricle. So this becomes very, very important. If the balloon is not crossable, then we have to cross with the wire, do rota, and then again, if not balloon expandable, then color. So rotatripsy is being considered in the algorithm, and very important one. Then coming to the PROTECT PCI, there is a simple protocol devised by Mount Sinai saying where we require impella and where we don't require. But key to note here, important point to note is here that a normal LVEF impella is not required. That is what it means. But we would like to know from the expert, are they doing protect PCI even in normal EF, LVEF or not? Then coming to the new studies which have come after one is visible heart study and another was Andreassen's benchmark study. And all these have evaluated the wiring aspect, distal wiring or proximal wiring, and noted what has happened to the cell size. So cell size remarkably negatively reduces when we do a proximal wiring, whereas distal wiring cell sizes did not reduce much. This is a very important factor which has been highlighted by these two studies. Similarly, they highlighted if port side by side port and where do we do a port, final port, and if it is done before the origin of the side branch, then results are pretty good as compared to doing it at the side branch. We know that when we do FKI, there is elliptical deformation of the stent, which is corrected by the port, two ports. One is the initial port, and then the second one after deploying the second stent in mini crush, we do a port in the left vein, and then after final casing, we do a second port. We are all aware of it. But we have to understand from our expert that perspective of this various techniques so that we can obtain good result, long-term good result. This is a technique which is just diagram showing if we have a proximal wiring and if we do a kissing, then what happens after the port? Sorry, if we do a port, and what happens after the port is reduction in cell size as compared to before the port. So port proximal wiring distal will give you a good size of the opening of the cell. Intravascular imaging can be done in the middle and post. But lately, Lumen 3 trial results have been reported, and they say that the stent optimization or no stent optimization, the long-term outcome is same, no difference in death and MACE rate. Then 5 years long-term results have come of 4 major trial on Lmca Pci and almost 4,000 patients. Only one trial, Excel, showed that the death is significantly higher with p-value of 0.04 and indicating that that the PCI in Excel may not be that scientific, but the conclusion came as acceptable revascularization 5-year result. So there was a controversy that this is beyond the science. If the mortality is high, which should be a single most parameter, if mortality is high, then it is not what you call a non-inferior to the surgery. Then another is a protocol of definition of MI that was not universal, so that also raised the controversy. So we looked at the global trial result of 5 years reported in 2016 at the TCT, and it said that the MACE rate, death, MI, and stroke is significantly higher in PCI arm with a p-value of 0.2. So they suggested that PCI are not inferior to CABG. Then we have this 10-year syntax result coming up in September 2019, and they suggested that if at all, PCI mortality, all-cause mortality is slightly lower, but not statistically significant. But other side, even in intermediate score, it gave a syntax intermediate score, it gave a good result. So this again raised the issue, and we are back to this heart team discussion where patient is the middle, one side surgeon, other side cardiologist. Surgeon is saying CABG it is, and cardiologist is saying no need of the knife, we can do this all from the wrist. So where do we stand as far as the guidelines are concerned? PCI is recommended for simple lesion with syntax score of less than 22. PCI for intermediate and high syntax score should be with the RTM approach. Basically, high syntax score, all should go for CABG except for those with the high ST score. So with this brief introduction, I would invite and like to get the perspective of all our experts on whatever introductory comments I have given in their talk. And of course, in the discussion and question answer, all this will come. I invite Dr. Sunil Rao, our first speaker. He is a professor of medicine at Duke University Health System and chief of cardiology, Durham VA Health System, America. And topic he will enlighten us on is physiologic or imaging assessment of borderline Lmca lesion, tips and tricks with case-based learning. Dr. Sunil Rao, please come in and kindly.
Great, thank you. Thanks very much. Can you see my slides?
Yeah, 1 minute. Let me come out of the share the screen.
Perfect. It's okay.
Taskbar is not seen.
No, Sunil.
Okay.
It's okay. It's okay.
I can see. Can
you go full screen? Can you go full screen?
Yeah. Go full screen. You can.
Perfect. Thank you.
Okay, great. Thank you, Vijay. Thank you for inviting me for this really interesting conference. I'm looking forward to hearing my colleagues and learning from them. My topic is to really think about the evaluation of left main disease, which, as you pointed out in your introduction, is incredibly important for prognosis for patients and determining whether revascularization is indicated. I have no disclosures. I want to thank Mauricio Cohen and Mort Kern for helping me with slides. I did borrow some of their slides. So let me take you through a case presentation. This is a patient that was referred to us from an outside hospital. She presented to that outside hospital with a non-ST segment elevation myocardial infarction. This is her first presentation of cardiovascular disease, but she obviously has several risk factors, a history of long-standing type 2 diabetes mellitus requiring insulin, hypertension, dyslipidemia, and CKD, although her serum creatinine is considered to be normal. Based on her weight and her age, her GFR is around 60 cc's per minute. She underwent invasive risk stratification at the outside hospital. And you can see here, it's a diagnostic cath using a 5 French. This is a JL catheter in the left coronary, really not what appears not to be a very strong injection. You don't see much reflux of the dye outside the left main ostium. There is some calcification at the roof of the left main, and they commented in their notes that there was significant dampening of the catheter pressure upon engagement, and they kept disengaging the JL periodically to avoid that dampening. You can also see that in the OM branch, there appears to be a significant lesion. Here in the RAO view, you can see there's a fair amount of MAC. You can see the OM lesion here is very tight, likely the culprit. But again, not a lot of dye reflux out of this left main, difficult to assess angiographically. There's that rim of calcium at the roof. And again, significant catheter dampening. They had a difficult time engaging the right coronary. It's a very, very high takeoff, almost coming off the left coronary cusp, but at least in this flush shot, does not appear to be any angiographically significant disease in that particular artery. So this is an elderly patient with multiple risk factors who now has what probably is left main disease along with an OM lesion. So, she was sent to our hospital for consideration of coronary bypass surgery. But let me pause here and think about this patient in perhaps a little bit of a different way. Rather than approaching this from the perspective of, what type of technique can we use? Can we, think about the distinction between CABG and PCI? Let's first take a step back and think about what are we trying to achieve when we're taking these decisions into consideration. So the goals of therapy, I think, for all of us who work in cardiology and in the cath lab are either to prolong life and or to improve the quality of life that these patients have. And so this, I think, should influence our decision-making because it needs to take into account the patient's preferences and values. Some patients may prefer at a certain stage of life to not undergo aggressive therapy, and other patients may, in fact, prefer to undergo aggressive therapy. And that definition of what is aggressive can vary depending on the patient. And so to achieve the goals, we really are obliged to use the best tools to make the best treatment decision. and of course, use all the tools at our disposal to make sure that whatever treatment we decide, we get the best outcome. And I would argue that in contemporary cardiology practice, this includes physiological assessment and really imaging-guided PCI, and that's what I will talk about over the next few minutes. So physiological assessment and imaging for left main disease, I'm going to go through three things. Why would you want to do this? What are the data? And then what are some best practices to make sure that you get, quote, the right answer for the right patient in the right situation? So why would you want to do this? And I think that this is something that hopefully all of us know, which is that angiography in and of itself is quite limited in terms of the assessment of the severity of coronary disease. We also know that anatomical obstruction is really just part of the picture, and we need to understand what the physiology is. Here are two examples. On the left-hand side, you can see in the top panel, angiographically, not very severe. However, when you do intravascular imaging, you can see that the MLA here is quite a bit less than what has traditionally been the cutoff for significant left main disease, which is around 5.9 millimeters squared or 6 millimeters squared. You can see that this is actually 4.6. So this is a patient who, if you had relied on the angiography alone, you probably would have said, well, this patient does not have any significant left coronary disease and can be treated medically. However, on the right-hand side, you can see that at least in the cranial views, where the left main can oftentimes appear severely stenosed, by angiography, you may say, well, this patient needs to have some kind of revascularization, either PCI or CABG. But again, when you do intravascular ultrasound imaging, you realize that there are different shapes of the coronary. And in this elliptical shape, the MLA actually turns out to be 8.6 millimeters squared. And this patient may, in fact, just need preventive therapy. So, you know, it's really important not to rely just on the angiography. And if you further data to support this is this study, which asked cardiologists and cardiac surgeons based on angiography, do you think that this left main stenosis is significant? And you can see that when they talk to the cardiologists, that there's a tremendous spread in what cardiologists felt was significant, even for lesions that had an FFR less than 0.8, which is our traditional cutoff. You can see that a tremendous number of cardiologists felt that angiographically this was a non-significant lesion. And again, given the mortality rates and the MACE rates associated with significant left main disease, this becomes a real issue. Let's say you say, well, I don't really believe that 0.8 should be the cutoff. Let's say it's 0.75, and we draw the line at 0.75. Again, you can see a tremendous number of cardiologists assessing this angiographically would say that the disease is non-significant. What about cardiac surgeons? It's almost superimposable. You know, it's just angiography is just so limited in what it can tell us that further assessment, particularly for left main disease, is really, really important. And similarly, if you look at the diameter stenosis on the y-axis here and the IFR, so this is the non-hyperemic index, you see that same spread where stenosis diameter and IFR simply just aren't very, very well correlated. So physiological assessment is really important, particularly for left main disease, where the outcomes are poor and the outcome improvement is dependent on revascularization. So what are the data around this? Well, this is a really terrific study where they took, it's a multi-center study, and they looked at predefined IVUS criteria for assessment of intermediate left main. So this is not physiology. This is, in fact, IVUS. This is one of the studies that looked at IVUS MLA cutoffs to determine prognosis. So in these 354 patients at 22 centers, they all underwent intravascular ultrasound assessment. And you can see that they were grouped by the MLA cutoff, less than 6 millimeters, which has traditionally been considered the significant left main disease, versus greater than or equal to 6 millimeters. And then they underwent treatment based on, you know, what those criteria were. And you can see here that in patients who had overall, with or without revascularization, there didn't seem to be a significant difference in the overall MACE rate. However, when you look at treatment according to the MLA, so not just angiography guided, but in fact, IVUS guided left main treatment, there really was a difference in the outcome based on whether the left main was deemed to be significant by intravascular ultrasound. So here is actual clinical outcome data showing that angiography alone for intermediate left main disease is not enough, and some other testing needs to occur. And in this study, it was intravascular ultrasound using a cutoff of less than 6 millimeters. Patients who had an MLA less than 6 millimeters who were treated with medical therapy and not revascularization had a significantly worse rate of survival free of cardiac death, MI, or any revascularization. Now, where does this, IVUS cutoff, how does it relate to FFR? It turns out that it's actually, the results are actually quite all over the place. I mean, if you look at the sensitivity and the specificity, in one study, it looked like it was reasonable for a cutoff of 5.9. However, in other studies, that cutoff was not 5.9, it was 4.8. So what is the cutoff? Can we actually hang our hat on 5.9 in all patients? Or is there some difference according to the patients and what their body habitus is, for example, or are all coronary arteries made the same? Well, I would argue that in North Carolina, where I live, where we tend to have larger patients, a 6 millimeter cutoff may in fact not be enough. Whereas in South Korea, which is where the Kang study came from, the 6 millimeters may in fact be sufficient. So there may be a difference in the MLA cutoff depending on how large the actual coronary arteries are. Now, the reason I bring this up is that, again, intravascular ultrasound is also an anatomical assessment. And so there are limitations to the anatomical assessment because of differences between patients and maybe even different geographical differences in the size of patients and what the size of their coronary arteries are. So in this context, it becomes really, really important to, again, rely on physiology, not just anatomy, but physiology, even if it's using intravascular ultrasound. In this really interesting pooled analysis, the conclusion of this was that IVUS of non-left main lesion has limited accuracy and should not be used to justify an intervention. Whereas in left main trials, the sensitivity and specificity is reasonable, but again, we have to take into account the differences in the patients that we're treating. So that's really where FFR comes in. And you can see that in this pooled analysis of FFR studies in left main disease, there was really no difference in major adverse cardiovascular events between FFR-based deferral, so no revascularization, and patients who got revascularized. What that means, of course, is that using FFR to determine who does not need revascularization is an incredibly important aspect of what we do. Otherwise, we will be subjecting patients to unnecessary revascularization where really no significant difference in outcome. Now, I should note here that in this pooled analysis, there was a slight increase in subsequent revascularizations in the deferred group. And that may, in fact, be partly due to the fact that there are limitations of physiology. And that is really where clinical judgment and taking into account all of the information to make decisions is important. It's simply not appropriate to use one test as a go, no-go decision. Now, this is the latest study. This is a hot off the presses, just came out a couple of weeks ago. This is, again, the Warasawa study that I showed you a little bit earlier. This is a multi-center study called the Define Left Main Registry, where they looked at 314 patients with left main disease, and they determined revascularization or deferral based on IFR. So not FFR, but IFR, which I think, at least in the United States, is largely being used in place of FFR to avoid the cost and potential risks associated with adenosine. As you know, much of the IFR data has been in non-left main disease, and this registry looked at using it in left mains. So 163 patients with deferral, if they had an IFR that was, quote, normal, that is greater than 0.89, versus revascularized if the FFR is less than or equal to 0.89. On the right-hand side, same graph that I showed you previously, really angiography was not enough to determine this, and IFR is really something that can be used to determine the physiological significance. This is really the rub here, showing that in patients who had a normal IFR, that is an IFR value greater than 0.89, who were deferred, they had very similar outcomes to those who were revascularized. So again, in this study, the use of coronary physiology to determine deferral of revascularization was associated with the same outcomes as if the patients were revascularized. So in this, again, taking into account the entire clinical picture, physiology can be very helpful to determine who does not need revascularization and who potentially who does. here are the meta-analysis of all the IVUS data. Something that I think we're all familiar with is that IVUS guided PCI. So this is not the use of IVUS to determine whether left main should be revascularized, but I bring this point up again to talk about contemporary PCI, use of intravascular imaging guidance to make sure that your stents are sized properly, that you have complete expansion and complete apposition is associated with superior outcomes compared with just using angiography. And I would argue that although we don't have solid data yet, to say this, I would argue that this is probably more important in the left main, given the high risk of patients having stent thrombosis in that particular location. So how should we do this? I mean, what are the best practices? So this is a really nice figure from Bhavik Modi's study in neurointervention from 3 years ago, talking about how to determine the physiological significance of left main disease when you have either branch vessel disease or it's a distal left main. If the LAD and the circumflex both have an FFR greater than 0.8, or if you're using IFR greater than 0.89, then you can say that the left main is not significant and that patient should get preventive therapy. If there is any discordance, then you can either do a pullback, or this may be the case where you can use IVUS as supplemental data. And of course, if they're both concordant, then the left main is significant and the treatment should be determined not just by the burden of coronary disease, but the patient preferences. So I put on the left-hand side here 4, I think, very simple to remember best practices. Remember to give IC nitro. I personally think that every patient undergoing angiography should either get a sublingual nitroglycerin or should get IC nitro before taking pictures. We all have cases where we've been referred for patients for PCI, where on the diagnostic angiogram, there's a severe stenosis. We put the guide catheter in, give nitro, and the stenosis disappears. So give IC nitro. For left main, disengage the guide catheter. This is particularly important for the case I presented where the guide catheter kept dampening. So disengage the guide catheter, normalize your pressure wire in the aorta, and remember to pull back to check for drift. Any change greater than 0.3 is generally considered, or 0.03 is considered drift. And if you have significant drift, you need to do the measurement again. So here's the case. So, you can see the guide catheter there, disengaged. You can see on the right-hand side there in this view, you can actually get the sense that there is a significant left main lesion there. They did a physiological assessment at the outside hospital, found that the IFR was 0.73. So sent them to our center and consulted CT surgery, but the patient adamantly refused surgery. So the CT surgeons were willing to do this. But again, this patient's preferences and values, she did not want bypass surgery. So she was referred for PCI. We did this using a left radial approach, given her bleeding risk, particularly her age. And you can see that we did IVUS-guided PCI of the OM, which we felt was the culprit lesion, and then did a long stent across the left, the circumflex, and just did final kissing balloons into the circumflex. You can see the final result there. Very, very nice result in the left main, LAD, and OM. So in summary, angiography alone to assess the severity of left main disease is not enough. So we have to use imaging and physiology as just part of the equation to determine whether revascularization is indicated. Although we all want a go, no-go decision, it is important to keep in mind that there's a complex equation here that involves physiology, imaging, angiography, the patient's risk, and the patient's preferences. If you are going to perform revascularization percutaneously, remember to use best practices. And I would argue that best PCI or optimized PCI in the contemporary era includes good vascular access and imaging guidance to optimize your stenting. And using IC imaging to optimize that is going to result in the best outcomes. So thank you again for inviting me to be part of this session. And I'm eager to hear what people's comments and questions are. Thank you. Vijay, I think you might be muted.
Thank you for your excellent talk. You covered virtually everything of how to derive to a point where revascularization should be considered or not to be considered. And I think you added that physiologic assessment and even imaging in some cases can be really very useful. Excellent talk. Now we invite for the next speaker, and question answer, as I said, will be at the end. So next speaker is Dr. William Lombardi, and he's popularly known as Bill Lombardi, and he's professor of medicine at University of Washington and Director of Complex Coronary Artery Disease Therapies in Washington. And he will enlighten on Lmca Pci, debulking tips and tricks with or without protected PCI. Something which is day to day in your practice, real world practice.
All right. So can you guys hear me? I apologize.
Can you just you know?
Can you hear me?
Yeah,
yep. Can you guys?
I can hear you.
Great.
I can hear you.
There we go.
I can see your slide, but just expand your slide.
You know, I agree completely with what. Yep. Yep. There it is. All right. I want to
not
just agree with.
Now it's so fine. Okay.
Perfect, William. Go ahead.
Okay. So first, just want to agree with Sunil that I don't know what an intermediate lesion is anymore. There's either physiologically significant or physiologically insignificant. And obviously angiography and IVUS do not describe that. So I think for everybody out there, make sure you do the right thing by getting good data. So I'm not going to show a lot of data about calcium management. I think the biggest reason most calcium trials don't show good outcomes is one, we tend not to randomize people who
Bill, can I interrupt you?
Two, I don't think we technically do it the way we're supposed to get good outcomes, especially in the left main, and that really comes down to the size of the vessel. So just to show 7-year-old male, you got chest pressure tightness, right spike, they progress. You got an ECT, which was positive.
William, so we are not listening properly. You,
sure.
Your voice is stuttering. It's going back and forth. So can you try something different?
Can you little bit adjust your volume, please, Bill? I think we lost him. He's there. Can you just increase your volume of your computer a little bit?
No, I have an unstable internet connection because I'm not close enough.
I think so. Internet connection is the problem. We can't do anything much about.
Okay, I think I'm better now. I'm standing right next to so we're good right here.
Okay, fine.
So you can here, back to the case. So here's the gentleman's angiogram. So you can see 3 heavily calcified spots in his RCA.
But
He's
really,
then got,
we are watching your face and not anymore your slides.
Okay. Let me escape out of this.
We can hear you much better, though, Bill. I think you just need to share your slides and it'll be good.
Yep, I'm getting there. Sorry about that, Dave.
There we go. Good.
All right. Zach
Perfect.
got this. There we go. Awesome. Okay, so here is the distal left main lesion. I did not do IFR of that, so hopefully Sunil doesn't get mad. So this gentleman actually was at an outside hospital and he was admitted that day, so he was not allowed to leave, and was told he had to have bypass surgery. So, you know, with ischemia out there, this patient in theory might have been ischemia, though it's more of a distal left main lesion. You could do cabbage, and obviously if they were going to get bypass surgery, you'd expect the LAD, the right, and the circumflex to get treated. And if we're going to do PCI, how do we do it? What is really best practices, as Sunil was talking about? Well, given the amount of calcium in this, you're clearly going to need to do atherectomy. The other piece you have to remember with atherectomy is you need to do it with large burrs and debulking, and as was brought up early, potentially IVL will help. So we decided to use hemodynamic support, and what you see in this film actually is an Impella for support, and the reason for that is because we were going to be doing so much atherectomy, and especially I was planning to use 2.0 burrs, as well as planning to do lithotripsy, where I would leave the balloon up in the unprotected left main for a long period of time. And so because of that, I wanted to make sure that I had support. The second thing you can see in this film is if you look carefully, there's actually a little black dot going down, and that's actually a fine cross, plastic micro.
I think we have lost his internet, it seems. Bill, can you hear us? We can't hear you. I think let's go for the next talk, because absolutely nothing is happening. The screen is static. Yeah.
Yeah, Bill just texted that he's, I think, having more computer difficulty.
So let me introduce you, David. So we have a next speaker, as there is some network problem with the bill with William Lombardi, Dr. William Lombardi. So we invite the next speaker, Dr. David Kandazari. He's a director of Interventional Cardiology at Piedmont Heart Institute and Chief Scientific Officer for Piedmont Healthcare, Atlanta, Georgia, America. He will enlighten us on Lmca Pci, bifurcation stenting strategy and technique, the case-based learning and education. Bill, David?
Terrific, thank you. Just wanted to confirm with everyone my slides are visible.
Yeah, slides are fine. Just expand them, please.
Well, amidst recent controversy with regard to left main PCI versus bypass surgery, some of which, Vijay, you've highlighted, and again, like Sunil and Bill and Julia, we're grateful to be part of this program. The procedural technique and strategy for left main PCI is perhaps less contested, but in some ways much less rigorously studied. My disclosures related to research and grant support from the interventional device industry, and I also received minor consulting honoraria. Very much unlike this cartoon of surgeons, which states, let's just start cutting and see what happens. In fact, instead, our storied path for left main PCI has been one traveled of dedication to not only developing an evidence basis of left main PCI relative to surgical revascularization, but informing patient selection and even dedication towards, as Sunil introduced, patient preference and patient self-reported health status outcomes, but equally to advancing skill sets, to advancing technology, in particular with drug-eluting stents, and certainly with regard to procedural technique. Indeed, like other non-left main bifurcation data sets, the evidence basis supports a two-stent method being associated with a higher risk of adverse outcomes for bifurcation PCI compared with a provisional or single stent technique. And indeed, the longitudinal or temporal trends in left main PCI have reflected this adoption in practice, as one example from the Asan Medical Center in Korea, which is a very high volume center dedicated to left main PCI. Over an approximate 15-year period, there is not only an increasing prevalence of distal bifurcation PCI being performed compared with isolated shaft or ostial left main PCI, but also an increasing prevalence of a single stent method, whether with provisional balloon angioplasty or not, compared with a two-stent technique. Nevertheless, a two-stent technique is required in approximately a quarter to a third of all left main PCI procedures. When a two-stent method is required, however, the technique, whether with regard to stent methods, has been largely driven by either institutional or operator preference rather than any supportive or directive data. From earlier left main PCI trials, such as the Syntax study, to even more contemporary experiences, such as Excel or Noble, there is a great variance in the methods applied by interventional cardiologists to treat left main disease when two-stent methods are applied, ranging heavily, again, based on patient or, on provider or institutional preference, from T-stenting or T-stent variants to the culotte method to crush techniques. There's one two-stent method that does require some dedicated conversation or attention, and that is the double kiss crush technique. From a procedural perspective, the double kiss crush technique certainly facilitates recrossing with a guide wire of the side branch after the initial kissing balloon inflation has been performed. But importantly, technically, when recrossing with the guide wire into the side branch that has been stented initially, the guide wire approach should be in the very most proximal segment of the side branch rather than the very distal segment, which we typically apply for a single stent provisional approach. With regard to clinical evidence, however, the DK crush technique in non-left main disease has been associated with lower target lesion revascularization compared with provisional and other two-stent techniques, in particular the culotte technique. And specific to the left main indication, the double kiss crush technique has demonstrated superior 3-year outcomes of target lesion failure and stent thrombosis. Interestingly, even compared with a provisional method, and certainly it has been shown to be superior compared to the culotte technique, both in intermediate and longer term follow-up with regard to TLR and stent thrombosis. And this is especially, as we'll soon discuss, when the bifurcation angle, which is an important determinant of technique, is very, very broad or wide. And in fact, in the European Society guidelines, at least as of 2018, this is the only technique for left main PCI, for bifurcation PCI, that has some level of advocacy, albeit a class 2B recommendation over provisional T-stent techniques. One of the limitations, however, of the double kiss crush technique is that there is very much limited trial experience with regard to presentation and publication, and therefore limited external validation of the double kiss crush technique. That is, most of the studies, the DK crush series of clinical trials, have been principally performed by the same investigational sites. And also across these trials, in the control arm, the comparator arm, there's quite variable technique, which may influence the differential outcome. And further, these trials, which principally have involved angiographic surveillance, what influence that might have on reporting outcomes or differential outcomes of TLR is uncertain. So more data and perhaps more external validation of the DK crush technique should be applied before advancing this as a wholesale recommendation. That said, a two-stent method is necessary in selected cases, as I've implied, in a quarter to a third of left main PCI cases. Certainly when the bifurcation angle is narrow between the LAD and the left circumflex artery, the shallow distal bifurcation angle makes carinal shift and side branch occlusion much more probable. In addition to that, when there's extensive disease into the side branch, in this instance, most commonly the circumflex artery, again, a two-stent technique is going to be required when the disease is less focal, typically defined as 10 millimeters or more in clinical trials, but widely variable in clinical practice. And then certainly a two-stent method with crossover and a provisional technique occurs when there's compromise of the side branch that can't be resolved with provisional balloon angioplasty. As Sunil introduced, what we do know is that in many instances of a single stent technique, when there's compromise at the origin of the side branch, and in this case, most commonly the circumflex artery, even in the presence of what might seem to be an angiographically significant stenosis, the hemodynamics assessment by FFR or IFR is frequently acceptable. On the other hand, what we know with imaging, however, is that with a single stent crossover technique, when there is perhaps a linear lucency or where there is some angiographic narrowing or side branch compromise, this is most commonly due to carinal shift and side branch luminal distortion. You're changing the more circular appearance of the origin of the circumflex artery to an elliptical configuration. And this elliptical distortion results in luminal compromise. And there is, at least in 80% of the cases, a reduction in the minimal luminal area, even though it may be acceptable by FFR. And so therefore, what the long-term outcome of such patients with reduced minimal luminal area but an acceptable hemodynamic result is uncertain. And what's controversial today then is whether this can be corrected or resolved and of clinical benefit with a single stent technique and performing side branch balloon angioplasty, kissing balloon angioplasty as a final maneuver. It's quite a common procedure in clinical practice among high volume left main interventionalists. It certainly reduces side branch restenosis in observational experiences from the COBIS left main registry from Korea, for example, or alternatively from the Nordic bifurcation study, albeit non-left main disease. And this may reduce side branch target lesion revascularization. But there's some interesting data too that suggests that provisional balloon angioplasty into the side branch could also increase the risks, conversely, of main vessel in-stent restenosis. As I've mentioned, an acute or shallow bifurcation angle largely dictates the stenting technique. And specifically for an acute or narrowed angle, this precludes selected techniques such as T-stenting or T-stenting variants that don't provide adequate coronal coverage, but alternatively might favor crush techniques or crush variants or the culotte technique. But very importantly, it also requires that the operator is very informed or considerate of the limitations of the stents that depend or vary based on product manufacturing with regard to expansion limits and cell geometry when extending into larger side branches such as the circumflex artery or the left anterior descending artery. Here's such an example of a very narrow bifurcation angle. This is a patient of mine with end-stage renal disease and distal bifurcation disease. And in an attempt for provisional technique, we perform stenting from the left main into the circumflex artery. This is almost trifurcation disease, but you can appreciate that the angulation between the circumflex and the LAD is quite narrowed. And we immediately expect this coronal shift that now compromises the left anterior descending artery origin that can't be recovered with provisional kissing balloon inflation. And therefore we transition to a culotte technique with a side branch, with stenting rather from the left main into the left anterior descending artery. And now we have still coronal shift into the circumflex artery. And so there's this tension, this push-pull of coronal shift that's very difficult to recover with kissing balloon inflations with a very narrow bifurcation angle. This is the final result, but interestingly, even though despite the application of intravascular imaging, this patient nevertheless presented with osteal left circumflex artery restenosis approximately 1 year later, and we'll discuss this in more detail as well. Alternatively, when the distal left main bifurcation angle is very obtuse or wide, this prevents full strut expansion in apposition with culotte or crush techniques, and conversely may favor T or T in protrusion or T variant techniques, such as an example in this particular patient with trifurcation disease in which the angle is almost opposed at 180 degrees between the origin of the circumflex and the left anterior descending arteries. And so in this particular approach, I perform a backstop technique with a balloon from the left main into the LAD, a stent into the circumflex artery, and then completing the procedure with a stent from the left main into the left anterior descending artery, and then kissing balloon inflation, and we achieve a very acceptable result with appropriate coronal coverage and no compromise of the ramus artery as well. Whether it's a single stent method or a two-stent technique, the Achilles heel of left main PCI is angiographic and clinical restenosis at the origin of the circumflex artery. In particular, in a two-stent method, this is most commonly associated with stent under expansion at the origin of the circumflex artery. Indeed, in a two-stent technique, nearly 40% of the cases when surveyed with intravascular imaging will have some evidence of stent under expansion at the origin of the circumflex artery. And in more than half of those cases, it's associated with clinical restenosis, that is the need for clinically driven repeat revascularization. Certainly and expectedly less common in a single stent method, but again, it highlights the importance of appropriate stent expansion and the application, at least in my practice, uniformly with intravascular imaging. Sunil addressed the use of imaging along with hemodynamic assessment for determination of left main significance. From a procedural perspective, data from Korea, for example, has suggested minimal luminal area thresholds or minimal stent area thresholds for achieving stent expansion that might mitigate against the risks of angiographic restenosis and clinically driven repeat revascularization. As Sunil also implied, in the United States population, we've simply escalated those standards at least 1 millimeter squared higher for minimal stent area in the different segments of the left main bifurcation, whether it's the origins of the circumflex or the LAD, or the polygon of confluence, that is the distal bifurcation segment, or the left main shaft itself. But perhaps the most contemporary data is not divisive with regard to minimal stent area in the different segments of the left main, but in any part of the left main treated. From Akiko Mahara in the Excel trial, there's a clear distinction in achieving a minimal stent area of greater than 9, in this case 9.3 millimeters squared, in differentiating outcomes associated with the left main segment. And specifically in a tercile analysis demonstrated in the right-hand panel, there's a clear distinction, a clear graded distinction that the higher minimal stent area achieved in the left main territory, the lower the risks over longer-term follow-up of death, MI, and stroke, death, MI, stroke, and repeat revascularization, and specifically with regard to myocardial infarction as well as stent thrombosis. To highlight this limitation of angiography alone from a procedural technique, here's an example of a patient whom I treated in a program for distal left main bifurcation disease. And angiographically in multiple views, the result appears to be very, very acceptable with appropriate stent expansion. But after kissing balloon inflation, when we apply intravascular imaging, as you can appreciate, moving from distal to proximal in the left circumflex artery segment, despite kissing balloon inflation, there's still this elliptical deformation of the stent at the origin of the circumflex artery and incomplete stent expansion. And while this is partially resolved with a repeat kissing balloon inflation and with high pressure repeat inflation with arguably an oversized balloon, it highlights our considerations or our thresholds for using atherectomy, for example, or other modalities for lesion preparation to achieve adequate stent expansion at the origin of the circumflex artery. Now, with regard to the decision-making for single stent versus two stent methods, at present, this is currently being evaluated in part in a randomized trial that I'll introduce in a moment. But in the Excel experience, among 529 patients with distal bifurcation disease, certainly the Excel trial did not mandate a single stent versus a two stent method. This was left to the operator's discretion. But overall, a two stent method was consistently associated with higher rates at 3-year follow-up of death, stroke, and myocardial infarction, and the composite of death, stroke, myocardial infarction, and repeat revascularization. However, when we adjust for the presence of what we term true bifurcation disease versus non-true bifurcation disease, that is disease involving both the origins of the LAD and the circumflex artery, when a two-stent method is applied, these differences are no longer at least statistically significant. Specifically, in the green Kaplan-Meier curve figure, the rate of 19.2% is associated with a two-stent method of death, MI, and stroke at 3-year follow-up when true bifurcation disease exists. This is numerically higher than a provisional method in true bifurcation disease with an event rate of 14.3% at 3 years, but it is no longer statistically significant. To be sure, when a two-stent method is applied, however, to non-true bifurcation disease, that is when disease does not involve both side branches, but yet for some reason the operator still elected to use two stents, this is associated, in fact, with the highest rates of death, MI, and stroke at 3-year follow-up. I'd like to comment, however, that procedural technique in left main disease does not occur by intention to treat. It occurs by improving one's skill sets by operator experience. And this still seems to be a limitation in selected geographies, for example, in the United States. From the American College of Cardiology NCDR database, for example, the overall prevalence in the latest survey of unprotected left main PCI is quite small for left main PCI in the totality of PCI procedures in the United States, representing fewer than 2% of all PCI procedures. And specifically by an operator breakdown, operators overall in the United States therefore perform fewer than 2 unprotected left main PCI procedures per year. Hospitals perform on average 3 per year. And in fact, the majority of operators in nearly half of hospitals perform less than one unprotected left main PCI per year. And because in many ways, many of these patients are determined to be surgically ineligible or so-termed surgical turndown patients, in the United States, unprotected left main PCI still seems to be associated with greater baseline comorbidities or the need for an urgent or emergency procedure, and expectedly it's associated with higher in-hospital mortality and major adverse events. This also raises the issue then with regard to operator experience on the operator volume outcome relationship. And this has now been recently studied in 2 geographies, both from the United Kingdom as well as in China. A recent study from the British Cardiovascular Interventional Society, for example, suggests that operator performing a limited number of PCI procedures of unprotected left main PCI procedures have higher cardiovascular mortality, and that this operator volume experience, certainly well with other complex procedures, as Bill knows well, such as CTOs, is very pertinent. It seems to be also very evident in left main PCI as well. From the Fuwai Institution in Beijing, China, not only a very high volume PCI center, but a very high volume left main center, operators performing at least 15 left main PCI procedures annually for the preceding 3 years have improved outcomes, in hospital outcomes, as well as in the BSIS experience, improved long-term cardiovascular mortality. And this seems to be independent of whether or not intravascular imaging is applied, whether or not it's simply limited to distal bifurcation versus non-bifurcation left main disease, and whether a 1-stent or 2-stent method is applied by these operators. In summary then, as emerging evidence continues to demonstrate equipoise between the revascularization strategies of bypass surgery and PCI for left main disease, our attention turns to the ever so needed important details of technique, of stent selection, and other issues pertinent to clinical practice, such as how we survey these patients over long-term follow-up, or what might be the appropriate durations of dual antiplatelet therapy. For 2-stent left main strategies, the determinants of technique and method not only include the extent and severity of disease, true bifurcation disease, the extent of disease into the side branch, but very importantly, the bifurcation angle. As I've implied too, and as Sunil introduced, not only for assessment of left main significance, but for the procedural aspect, intravascular imaging and hemodynamic assessment are complementary, but also imperative. 100% of our cases at least employ intravascular imaging with either IVUS or OCT. The outstanding issues in a 2-stent left main bifurcation approach include not only what is the appropriate 2-stent method, is it the DK crush technique with still limited external validation, but also methods for appropriate lesion preparation, as Bill Lombardi was implying and introducing to us, to achieve acceptable luminal gain, especially at the origin of the circumflex artery. It's important to note too that at least at present ongoing is the EBC main trial, which is comparing a 2-stent method versus a provisional stent technique in true bifurcation disease. And I think this will be a very informative trial and an extension of the data that I shared with you from the Excel trial, suggesting that a 2-stent method may be acceptable with regard to long-term outcome in true bifurcation disease, but still numerically higher than a single stent approach. Nevertheless, failure to have complete resolution of these issues certainly doesn't prohibit advancement of unprotected left main PCI, which at least in most centers in the United States seems to be quite limited, but very common at our institution. And it certainly can, but however, getting greater fidelity or resolution of these outstanding issues can only improve patient outcome. So thank you again, Vijay, for having me as part of the program, and we'll transition on to Julio.
I think William.
Thank you, David, for excellent talk. And we will take question, answer, and discussion at the end. Julio, can we ask Dr. William Lombardi to complete his talk? He's back again.
Absolutely, yes.
Okay. So, Bill, please.
Please, William.
Yeah.
No voice again. No.
Yeah, I think you're on mute, Bill.
just
Unmute now. Can you hear me?
yeah, we can hear you.
Excellent.
Excellent.
There we go. We're getting closer here. All right. So as we were talking about, we have our distal left main lesion. And again, as everybody said, one, I believe in physiology. Two, I think the importance of the left main is atherectomy. So this is obviously heavily calcified. The plan here was to do rotational atherectomy of the left main to circ with a 1.5 burr, then rotational atherectomy of the left main to LAD with a 1.5 burr and a 2.0 burr. And I think you've got to, one of the things you got to be very careful with the left main is, remember in the old days, burr to artery ratio was about 0.5 to 0.6. Well, in a left main, that means a 2.0 burr is barely 0.5 because most people's left main is greater than 4 millimeters in diameter. So I think one of the reasons we've seen bad outcomes with calcium in left mains is people are not being aggressive enough with burrs. And I think the intravascular lithotripsy can be helpful. So one of the tricks that I wanted to show people in this case is there's often lots of concern about losing a side branch, especially an LAD or a circ, when drilling the left main. And obviously in this case, the LAD is very tightly blocked, as is the circumflex. So what we did actually, there's a roto wire down here in the circumflex. There's a workhorse wire in the LAD, and this is a fine cross. And this was a trick Kevin Croce told me. And you put a plastic catheter, you don't want a metal catheter, plastic catheter, and then you actually drill along the side of the plastic catheter from the left main into the circumflex. So the LAD is protected the whole time that we're drilling the circumflex. You will get some ablation of the plastic if you stay at it a long time, but usually you're doing this for very short distances. So this is a way of actually protecting the side branch while doing atherectomy. So that's what's going on here. We then removed the circumflex. We did rotational atherectomy, again with a 1.5, and this is with a 2.0 burr of the left main LAD. Then again, as we talked about, we used intravascular ultrasound. So we took a 4.0 lithotripsy balloon because the proximal LAD was 4.0. So this is IVL in the United States. Unfortunately, we only have the peripheral version, which is why you see it hanging out so much. But we did 10 cycles or 10 treatments of the left main. So again, the reason for the Impella was to give us time to do this. So the next piece in this is I tend to do my left mains backwards. So when my plan here was to do a 2-stent strategy because of the disease at both branches, but I tend to make the vessel with the shallowest angle actually the daughter, which means I tend to make the main branch actually the left main to circumflex. And the reason I do that, I think Dave's case pointed out well, is the circumflex has more annular ring of tissue around it, and the stents need more radial force to keep that open. I think that's why you get the elliptical force. So I tend to stent left main to circumflex. Therefore, I get more radial strength on the ostium of the circ. And also, it's much easier to recross in the LAD because the LAD angle is so much more favorable. And it actually, from the mental perspective, makes it easier to open struts. So in this case, I'm going to crush or mini crush and do a DK crush on left main. So you can see I put a balloon in the circumflex. I'm now going to deploy my stent. I will pull the balloon back to crush the stent. And the reason I do that is people sometimes will take the balloons in afterwards, but they can catch the edges of the metal. So it's easier just to have the balloon downstream and pull it back and then immediately crush. So there's my crush. And then we're going to, I think, recross here. I'm just potting, sorry. So we potted, we recrossed, we kissed, we re-imaged. And we had 9, 10, 11, Dave, so I think I was pretty good. And then we went ahead and did rotational atherectomy, IVL, and got it. And so I think the highlight of this is if you're going to do that, one, we underutilize rotational atherectomy in left mains. And the reason we underutilize that and orbital atherectomy is the fear of hemodynamic collapse and compromise. With Impella, with good technique, you can really avoid these problems. So I think the first thing is, because debulking, because there's so much plaque in the left main and it's such a big area, I think it's very important for people to have a very low threshold to do atherectomy. And I think clinically, as Dave was showing, with people doing very few of these cases, there's actually the reverse, which people are afraid to do atherectomy in the left main because of the potential consequences. So we actually underutilize it, which in the trials then means we get worse outcomes because we're not actually being as effective in optimizing the stents. So I think for those of you who are going to be doing left mains, one, you want to do more left mains, not less, because numbers matter. Two, you want to do more atherectomy to help with plaque shift, debulking, optimal stent expansion. And the third is either use high-speed orbital or use large 175 or even, I think, more recommended 2.0 burrs in the left main to help get maximal stent expansion. I think IVL on top of atherectomy, because I think what you'll see is you still need atherectomy to make a channel to deliver IVL and to make sure that you get optimal stent expansion using intravascular ultrasound. So not a very data heavy slide. I'm more of a technical guy. I let Sunil and Dave be the smart ones. And I would just tell you is I think that overall, what I'd like to see people to get better outcomes and equivalent to surgery is we have to do our job at a very high level. And left main PCI is the highest level of doing that because the risk is the highest because of the concern of loss of the side branch. So thank you very much for having me. I hope that's an interesting case for people to look at, a way of looking at a new way of protecting a side branch when you do it. And also I hope people take away that they need to be much more aggressive in about debulking and about sizing when it comes to managing the distal left main. Thank you.
Thank you, Bill. Excellent talk, superb talk, and you demonstrated a very good case in which you showed how to handle the calcium. We'll do more question answer after Julio's talk. So let me invite Julio to Dr. Julio George-Lumi will deliver us a talk on intravascular imaging in Lmca bifurcation PCI, tips and tricks, the case-based learning and education. He is a director of Interventional Cardiology and Cardiovascular Department at Ospedale Giovanni 23, Bergamo, Italy. So, Giulio, can we have your slide?
Yes, of course. Thank you very much. Can you see my slide?
Thank you. Yeah, of course.
Okay, first of all, happy to be with you. And happy to have listened David, William, and Sunil talking about a low threshold for using imaging in left main bifurcation PCI. This is my disclosure, full disclosure. Let's start to talk about the evidence and what do we know about the recommendation for using imaging in a distal left main. Here you have data from IVUS Troncu study. There is a pool analysis of 4 left main PCI Spanish registry. We are talking about more than 500 patients with IVUS guidance, left main desimplantation, and there were propensity score matched with angio guidance. On the right side, you can see clearly that the subgroup with a distal lesion had a significant benefit in terms of MACE, and especially the subgroup with a distal lesion and 2 stents, was mentioned many times today, had a highly significant benefit in using imaging. Let's spend a few slides about on how to use imaging. So the use of imaging for having some clinical impact is based on measurements. Which type of measurements? Well, you can get all the type of measurements. You can decide where to land with a stent. You can get information about the entire length of the stents, but also during the procedure, you can know about how long should be the pot balloon for finishing your job. Which type of technique should be used? Only IVUS? Not only. Here you have the data coming from the OCT user. They are showing the fact that when you are talking about the ostium of the left main or a short left main, you can lose some significant percentage of the frames where you can do automatic measurements with the automatic control. The more you are approaching the distal left main, the lower is the number of frames that cannot be automatically measured. So as impact on the daily practice, the left main bifurcation is perfectly evaluated by OCT. The intention is not only to take measurements, but more specifically to orient on the strategy. What does it mean? That based upon the type of substrates you are dealing with, the distal left main and the landing zone, you can decide if you can go directly, if you need some conventional standard approach with a compliant balloon, if you need it to be much more aggressive when you have a calcification and the border of calcification with the bulking, and which type of the bulking eventually to use. Very essential to decide where to land. So the geographical miss is something that you can clearly perceive by using imaging, both a type IVUS on OCT, and so they are sites where is absolutely unsuitable to land your stents, especially when you have a full lipid-rich plaque, and they are in opposite way, site where you can safely land your stent when you are dealing with a normal tissue, fibrotic, or when the calcify is quite large and leaving you to finish. It has been mentioned that angio give us some false impression of the beautiful results we might achieve with the stents. Here, one example of a nice result with a provisional one stent from left main to LAD with a clear evidence of suboptimal results at the distal level, the dissection, and inside the left main with hidden malposition. This is not only with IVUS, but is equally true when you are using different technology. Here you can see some nice results obtained by a provisional one stent kissing balloon plus a pot, and the evidence of a hidden intramural hematoma. Of course, IVUS has some issue, and you can make much more clear your imaging. Just injection few cc of saline or contrast to clean the lumen and identify the hematoma at the origin of the circ. Talking about the essential today in terms of case-based, we are focusing on calcium. It has been mentioned why calcium, because the population is becoming older and older. There is an increased rate of diabetes, renal failure. Here you have the same left main assessed by pair imaging with IVUS and OCT. If calcium is important, both the technology can detect, but clearly OCT has a much higher resolution, so you can get more information compared to the shadowing due to the IVUS highly calcified vessel, because you can penetrate the calcium and you can take different measurements. Why is important? Because we heard that you needed to be more aggressive, you needed to change your lesion preparation. This is the case. 66 years old female, unstable angina, prior multiple stents on the right coronary artery. She went back with unstable angina. And you can see before injecting the contrast, the clear calcification that you have at the level of the left main and in both vessels. Left main bifurcation Medina 111. This case was approached by using OCT. So you can clearly see on the right side the catheter, left main, and the bifurcation, and the type of information that you can get when you are doing a pullback in a few seconds. So here you can see some calcification, very small, nodular, deeply located, no issues in expanding this segment. Here you can see a much more proximal calcification. Here you can see possibly not calcification plus some thrombus. Here you can see at the level of the distal left main, a huge arc of the calcification that is very thick. So you are taking a single pullback and you have a multiple information. And here you might see that beside the calcification angle and the length, you can also measure in the minimum lumen diameter, and you might have information about which type of, for instance, burr to select. And here you might have information about the thickness of the calcium. But at the same time, we are taking measurements with the same pullback, where to land. I was mentioning before that many times you have a false measurements obtained by the lumen profile. In this section that we selected for landing distally, you can see that the diameter of the lumen was 2.28, while the media to media average diameter was about 3.4. And then substantially, we are taking the same measurements at the level of the second vessel, the circ, because when you have both vessels involved, this is the rule, you need to assess both vessels by using imaging to be sure about the method used. Here you can see that in the circ, we had much less calcification, nodular, very superficial, and very limited. So much less issue compared to what we had on the LAD and the left main. In this case, based upon the diameter that was 1.46 at the level of the distal left main, we use a Rotalink burr of 175 high speed, and this is the results after this bar. And then we are going to reassess again what was achieved. Here you have the longitudinal view, the automatic lumen detection pre, and the 3 cross-sections showing different level of the left main with the bifurcation and the thickness of the calcium. Here you might see, after the rotational atherectomy, the impact of 175 burr. Then we might have some accurate assessment of how much is still remaining in terms of calcium thickness, still a lot. And then you can have a look to the automatic lumen detection border that is showing you that we achieved something, but definitely it was not optimal. So in this case, was before having lithotripsy, we went back with the scoring 3.5, then quantum, non-compliant balloon, high pressure, very high pressure, so high pressure that you can see that we were dissecting the proximal ostium of the LAD, but there is still some ring at the level of the balloon. So then we progress with SCS stent LAD left main, kissing balloon, and then we have this type of assessment. We did a second stent in the circ. So here you can see the pullback from the circ after this stenting, and you can see that in fact we achieve a beautiful expansion, and the lumen was very acceptable, round in shape. Sometimes there was some remaining nodular calcification that was protruding, but with an area that was 5.63. OCT is not IVUS in terms of sizing, but is pretty close. And then we can trust on the numbers that you saw before, while we are waiting to get the numbers that derive from OCT big trials. Sorry for that. I'm sorry, I don't know why we went back. I think there is something that was not okay. Okay, sorry for having this limitation. So now we are going with the second pullback. So we saw what we achieve on the L6 left main. And now we are going back to what was achieved at the level of the LAD left main. You may see clearly that number one, we got fracture that were clearly identified by these small spots. That you can clearly see that there was a huge amount of calcium remaining, and that the expansion was extremely suboptimal. So we did rota, we did cutting, we did DK crush plus high pressure pot, and this is the inside results, how you can get from imaging. Here you have the 3D view, forward view, showing the protrusion of the calcium at the level of the distal left main. This is the ostium of the circ. This is the backward view, showing the same protrusion. This is the fracture that was achieved with this incredible amount of calcium that is still limited the expansion to 68%. So baseline, and here is the final angiographic results. And here you might see how much the angio can be misleading in terms of optimal results. You can see what was achieved with the rota and what was achieved with aggressive technique with a fracture, and apparently a nice result. So the first message is, well, you needed to use imaging at a different time point before to evaluate and guiding, and then during the procedure, especially when you have a huge calcification, and then at the end for having some acceptable measurements shown on your result. This is a second case to be politically correct, done by using IVUS HD. So 60 years man, unstable angina, 3 vessel CABG in 2011, LAMI on the LAD, and saphenous vein graft on the second margin, and that was dominant. He went back with unstable angina. Here you might see the IVUS pullback from the circ to the left main after the pre-dilation. And so you can clearly see on this spider view that the ostium of this larger territory was very narrow. Here you can see that it was almost calcified the entire vessel. Here you have a tight stenosis on the middle of the circ, 360 degree, essentially in this IVUS nears, almost no lipid. And then you can see the ostium of the left main that is identified by this second rest spot with a very small diameter. So in this case, it was done more recently. We went with a shockwave, and the selection was a 3-5-8 cycle. And this is the results after shockwave. Seems very promising. This is the imaging assessment after the shockwave 8 cycles. You can see that the MOD is still very, very narrow and limited. There is the evidence of some fracture line, but for us it was not enough. So we decided to go with a bar. We base the bar upon the MLD, so we use 175 high speed. This is after rotational atherectomy. We were able to achieve a larger lumen, as you might see in this first cross-section with the same evidence of a fraction we had before. The calcium, of course, was also partially impacted at the mid of the circumflex. We derive the lengths of the stents based upon the longitudinal view. This is quite important to try to optimize also in IVUS the longer view. Here is the placement of the stent from the circ into the left main. We selected 4.5 plus a high pressure non-compliant balloon 5.5. This is what was achieved. Extremely good in angio, very acceptable in the true ostium of the left main with a huge and wide area. Acceptable with a 12.5 millimeters square. Please go back to the slides show a few seconds ago from Akiko Mehara and the Excel data. And so we achieved something that was clearly much better compared to the beginning and the nice results in the SIRC. This is objective measurements done at the end. Here you have the pair session at baseline, left main ostium, that baseline after shockwave, after rotational atherectomy at the end. And this is what was achieved at the proximal circ that has much less concentric calcification, and it was much easier to obtain. We went before through this slide. We know that IVUS has already some clear measurements identified for getting optimal outcome. And in this case, the results was achieved. The message that I wanted to highlight is in this situation where you don't want to go blind in your decision, you need to use imaging before, imaging during, and at the end of the procedure. You know that to have a detailed protocol perhaps is much more demanding, but is extremely important to have some significant impact. These data are coming from José de la Torre, the same main author of the Litro stent study, where you can see that when you are following a protocol by using imaging, assessing landing lengths, expansion, you might achieve a much better survival compared to the angio guidance and possibly better compared also to the standard IVUS occasionally used. What about the left main OCT analysis? So some tricks. Avoid, if you want to use OCT in left main, very aggressive left main cannulation. Check and seat the catheter position in LAO view. Increase the field of view of the OCT machine. Improve flash quality. Coaxial injection, very, very important. Check the imaging before doing the pullback all times. Just a single puff 3 cc through the guiding catheter can make you convinced about the level of quality of your following pullback. Try to get a proper contrast injection with no blood during 3 seconds, and normally the injection debit should be increased. I'm finishing to say that, in my view, imaging is positive overall to the results of left main PCI, particularly for distal lesion and particularly when treated with a 2 stents technique. The study supporting IVUS imaging guided left main PCR are now essentially based on IVUS, but we know that there are large ongoing advanced OCT trials mentioned in the name, October and Lemon, that will bring data. OCT is not suitable for ostial lesion, very short left main, and more technically demanding for blood clearing. But OCT is a little bit superior for calcium, cell wiring, detection of dissection and malposition, and we saw 3D bifurcation assessment. Clinical impact of IC imaging needs, in any case, accurate planning. So do your imaging pre-procedure and plan what you are going to do, measurements, and post-stent evaluation. Thank you very much.
Thank you very much, Julio. Excellent talk and beautiful images. Very clean and very nice imaging images. Wonderful work. In your practice, Julio, how many times do you image all cases of left man in your practice?
No, really, because my partners sometimes are coming back and say, why do we need? But I think they are becoming more and more convinced. One of the limitations is, of course, cost reimbursement and the training. Training is important to be highlighted because I was saying, if you are using imaging, you must take measurements. Just running one pullback and say in a single cross-section, well, this is the MLA, is not enough. Base your strategy on imaging is more demanding. We needed to form and to teach the people on how to use it, and you needed to provide the data about the outcome advantage.
Absolutely. And then how do you select the cases? If you're not doing it for all the cases, then how do you select the cases where imaging to be done?
Well, I'm a little bit open. In any case, when you have a calcification, I think this is one clear plus.
Absolutely.
When you have a recurrence at the distal left main is absolutely a plus. And then I think that the limitation of OCT, I was saying, is you needed to have some normal section in the left main. If you have extensive disease, I'm going with the IVUS. If you have renal insufficiency, I'm going with the IVUS. If you have truly ostial disease of very short left main, I rather prefer IVUS. But otherwise, we can do both. And you saw that you can be accurate. We need a better catheter. Definitely, we are stuck with this catheter performance. Many times we need to pre-deal aggressively, because the people who are customize imaging, they are thinking about imaging quality and not to the fact that for the interventionalist, the first major point is to get into the lesion. If you are in trouble in bringing the catheter down, that is going to be very discouraging and a major issue for guiding the procedure with imaging.
So essentially you're saying that the imaging in the calcium, that is must, and
calcium,
then
recurrence,
ostial lesion, left main ostial lesion.
And the recurrence, restenosis, stent failure, absolutely.
Absolutely. And for
Vijay,
optimization, do you use it for optimization?
Sorry.
Optimization, do you use it?
Well, absolutely, yes. If you are working with the two stents, so I think that somebody was talking about recrossing of the cell. It's not very simple. At the beginning, I'm not recommending to do as a first attempt in guiding the procedure with the left main. Very important, because optimization is starting from the beginning. Landing zone is essential, and especially with the left main, when perhaps you have a discrepancy in caliper between big left main and a much smaller vessel, is crucial to define where to land your stent and then expanding or overexpanding. But perhaps the vast majority of the recent generation of the DS may allow a wide range of expansion, of overexpansion.
Okay. Sunil, now there are several parameters the hyperemic FFR with the proper, which we do original FFR I'm talking about, followed by a sub-hyperemic FFR, and then there are no hyperemic FFR, which are done with several of them. But many companies have their different FFR, and some are using full cardiac cycle, some are using cardiac diastolic cardiac, only diastole, and some even using further sub-styled. So how do you assess, how do you, be sure that you are doing a right FFR?
Yeah, I think some of these debates around the different techniques to use are largely academic in my view. I think, many of these have been validated, and I think that I think the real struggle is to make sure that people are using some type of physiological evaluation. I think what Bill said at the beginning of his talk is really important. It's not really clear what is an intermediate lesion anymore. There is physiologically significant and non-physiologically significant. So trying to get away from the angiography alone is really the struggle. Once that happens, we can have academic debates at conferences about RFR versus IFR versus OFR. And I have no doubt that over the next few years, there will be entire sessions built on these debates. But that to me gets a little too far into the weeds. I think it's really important, particularly in the United States, where we have a proliferation of operators who are really doing very, very low volumes every year, trying to get everyone on board to doing the best that they can for the patients is going to be really, really important.
So physiologic testing, naturally we don't do for all the cases. How do we select the case for, one is intermediate lesion.
Yeah.
Any other subset where you would like to do a FFR?
Yeah, I don't know if any of you have ever seen the movie Ronin with Robert De Niro, but there's a great line in there is that, whenever there is a doubt, there is no doubt, right? So you should not leave the cath lab with any doubt about whether you did the right thing or what the diagnosis is. I mean, the thing that I think irritates me the most is when someone does a diagnostic coronary angiography and the plan is a follow-up stress test. That does not make any sense to me. And I think it's the wrong order. So if there's anything, we have to apply clinical judgment. And if there's anything in your judgment that says that I'm not sure what's going on here, I think you need to get more information, and physiology is part of that equation.
Sunil, just as a corollary to that, with the increasing prevalence of CT angiography and the application of CT FFR with it too, I've been impressed at the number of patients coming in who, to highlight your earlier comments about the limitations of angiography, have significant disease identified by CTA, either by imaging alone or CT FFR. And angiographically, it's not something that I think many operators would even think about who do FFR, IFR would assess. And yet when we do it, sure enough, it's hemodynamically significant. And then we apply IVUS, for example, or OCT imaging, and then you really see the true extent of disease. So that's one comment I wanted to add, to expand upon too, is that that really it highlights the limitations when we don't do physiologic assessments. The second is that there are, I'm also impressed with contemporary data from a recent study, for example, highlighting how when we treat lesions with a stent procedure, that a third of the time we'll still end up with an inappropriate hemodynamic response, because a third of the time miss more proximal to the stent that we thought was a perfect result, a third of the time for disease more distal, and a third of the time due to stent under expansion.
Okay.
If I could just comment on this discussion, I think the challenge actually Gero brought up was the most appropriate, which is the real problem we have is bad training, which is it shouldn't be, I'm going to selectively use physiology. I'm going to selectively use imaging. I'm worried about cost management. The thing you have to think about cost is if you use imaging, you actually save money to the healthcare system because you reduce rehospitalization, TVR, TVF, and death to such a rate. So like our institution, 92% of people have imaging with their PCIs. And it's because there isn't a selection. It's the right thing to do for people. If I was going to get a PCI, I'd want physiology and IVUS. If it's right for me, it should be right for everybody. I think the second piece of that, though, is we have lots of people who do quote unquote high volumes, but they don't do it well. They just do lots of it and doing lots of the wrong thing. It's like being a golfer. If you have a bad swing and you slice the ball to the right every time, and I go to the driving range and I have 1,000 balls and I'll slice to the right, I'm not getting better. So you really want to work on is the mentoring and teaching. You know, I have a close person who's involved in imaging, and they were in a case. The doctor puts an IVUS in after deploying a 3.0 stent and a proximal LAD. The IVUS shows that the LAD is a 4-5 vessel and the stent is woefully underdeployed. And the doctor goes, that's fine. It's okay. I mean, even with the picture drawn showing they've done it wrong. And it's because they haven't been taught or held accountable. So I think these talks have been great because they're all very consistent about we should do physiology. We should do better vessel prep. We should use imaging to get optimal results. But if we don't do that in studies, we don't do that in clinical practice, we aren't going to get better. So I think that to me is the take home of this is for the participants is you need to change how you practice and you need to get better coaching to help you get better at what you practice to be a better operator.
Another thing is when you have a left main size, Bill, of 5.5 or 6 millimeter, which stent do you use? It's not uncommon to see 5.5 or 6 millimeter vessel.
Yeah, so most of the 4.0 stents can get up to 6. The metal may foreshorten a little bit. Obviously, there are now some dedicated 5.0 stents that we have in the US, so we tend to use a lot of those. I think the more important question that people need to understand is, you know, if you start doing a lot of imaging, what you realize there are a lot of 5.0 right coronaries and a lot of 4.0 or 4.5, 5.0 proximal LADs and proximal circs. And if you put a 3.0 stent in a 5.0 vessel, you cannot make it 5.0. So I think that the important piece is to make sure that you pick a big stent to start, which means you need to image before you deploy the stent. I was in South Africa earlier this year in Durham, which has a large Indian population. And the physician said, no, Indians, their vessels are very, very small. And we actually he did an IVUS and we put in IVUS and they weren't small. They had a lot of disease, but they were huge vessels. And so I think a lot of the times when people talk about small vessel disease, it's not small. It's just angiographically doesn't look great. So, you know, I think it's more important to know your size before you go.
Absolutely. Imaging plays a role in deciding the size of the vessel.
Yep.
And David, what's your choice of drug in a 5.5 to 6 millimeter vessel, left main vessel? Because none of the stents have that size available. Because there are so much, when you deploy the pressure at a high pressure, any stent, there is a polymer discrepancy, then there is a drug coated which is there, it can be discrepant, then that also will affect the long-term result. Am I right or wrong?
No, there are two issues here. One is, first of all, like Bill implied, the recognition that the vessel is actually that large. Yes. And the second issue is then in terms of the stent type, like Bill mentioned, we have drug-eluting stents now that are 5 millimeter stents that are tailored specifically with either thicker struts or greater radial strength, which I think are very good for left main disease. And 4.0 stents, as Bill mentioned, also can be expanded generally to about 5.5 to 5.75, depending on the manufacturer's specifications. But the things to think about with the extreme expansions of these stents are, as Bill mentioned, one, shortening of the stents, and two, perhaps spreading the cells so much that you get a lot of plaque prolapse, or you have inadequate radial strength. And we were the highest enrolling center, for example, in the Excel trial, and we noticed, for example, with that particular stent, there were a couple of cases where we truly had imaging documented recoil of the stents within the left main, where we have to buttress it or fortify it with a stent within a stent because of adequate expansion with a balloon, but then immediate recoil thereafter. It's uncommon, but I think the big issues are thinking about foreshortening and thinking about plaque prolapse as well.
Okay, then how do you, another challenge that we have in left main PCI is, which is Achilles heel, that this side branch coming back, left circumflex coming back with the restenosis. Already there are 3 layers of metal. With any technique, minimum layers of metal is 3. So how do you then, you can't consider again another stent in that area, that will be too much metal.
Yeah, I think it very much depends on the specific instance. We don't have available to us in the United States drug-coated balloons as of yet. So that's a significant limitation for us. I think that depending on the circumstances, and again, uniformly with imaging, we may think about if it's a stent under expansion issue, is this something that could be addressed simply with some type of ablative procedure, either laser or atherectomy, and then balloon angioplasty to better expand the stent? Is it something that is it a patient who would then qualify perhaps for bypass surgery, depending on the anatomy? And the other is that if it's certainly a single stent case, or if we can focally put in one stent and place it within 2 layers of stent, that's better oftentimes than balloon angioplasty alone. But there's pretty limited data on the management of this issue of in-stent restenosis, in part because, as I shared with you, in the United States, left main PCI is still relatively infrequently performed.
I came across a paper where they have a RCT done with the drug-eluting balloon and stent. Either stent or drug-eluting balloon was placed in the one arm, drug-eluting balloon, another arm, only stent, drug-coated stent, in ISR of side branch circumflex. And the result was amazingly good with the drug-eluting balloon than with the stent. And this was a good 300 patient study and followed up over a period of 2 years, angiographic follow-up, and excellent result. So maybe drug-eluting balloon will have a future. Earlier we had a plaquelet axle balloon, which was not so much acceptable for most of the interventional cardiologists. But now there are sirolimus coated drug balloon available in India, which is manufactured in India and is used also in all over except in America. I think in America also it's about to get FDA approval. And that drug-coated balloon with sirolimus-coated drug is supposed to be very good. It's called as Magic Touch. It's an Indian technology which is introduced with the sirolimus coating. Yes. So that is one area which was always a challenging aspect of the left main PCI, the ISR coming back in the side branch, and then managing it is always a very big challenge. Which stents?
May I make a comment?
Yes. Yeah.
Okay. I wanted to follow the recommendation from William because it's very important. I think if the patient is coming back with the 3 layers of stents, there is something wrong that can be anticipated when the patient is coming back the first time to try to understand if the stent was underexpanded. First, he was mentioning the type of mechanism of restenosis. If you have a neoatherosclerosis, it's completely different. The drug-coating balloon are much more effective if you have hyperplasia, less effective if you have a neoatherosclerosis. If you have a calcium neoatherosclerosis, you needed to change the strategy. So my personal recommendation, following the ones of William, is you needed to anticipate the time of use of imaging for understanding and avoid to have a recurrence and have a better outcome.
Absolutely, I think. And about the about which stent do you use in the ostium of the left main? Because usually it's a big challenge using open cell design, and results are not that good. Then do you have a closed cell design stent, and which stent do you use?
Well, politically correct, I'm not mentioning the manufacturer. We have multiple stents. I think we are open in Europe. We are quite happy to have some product launch before the approval in US has been mentioned before, perhaps thicker strands, perhaps with a higher radial force. I think that is also a matter of the size. What has been said before is absolutely correct.
Absolutely. But nowadays, all the latest third generation stent have smaller and smaller struts. So radial strength is reduced. Though they are using a proper alloy, which provides greater radial strength, but the strut size also equally important in providing a radial strength. How do you counter that, Bill?
Well, honestly, I think that that's sort of like Sunil was talking about, which is talking about IFR versus RFR versus OFR and whatever FR. I mean, that's a nuancy thing that I don't think anybody can prove any real data that radial strength matters. I mean, you could make an argument in a 5.5 left main, why do you need a drug-eluting stent? The restenosis of a bare metal stent, well opposed, would be so low you couldn't run a clinical trial to determine it. I think what's more important is that people do the job properly, which I think we've talked about at length. Make sure it's real, none of this indeterminate stuff. Make sure that you image and do vessel prep based on imaging and maximize and optimize the stent, and you'd have a lot better long-term outcome. I could make a very lucid academic argument that almost all of the interventional trials done are useless because very few of them actually use good technique. So it's hard to make good discussions around it. So I have basically 4 choices of stents in the US. They're all roughly the same, but you do what you do with what you have. I think, like many things, sometimes it's not the golf clubs, it's the golfer. And if we spent more time working on the golfer rather than the golf clubs, we'd actually have better outcomes. And I think that's, to me at least, my mission has been really trying to work on people's competencies and attitudes and potentially being a little bit more binary than a lot of my colleagues about, you know, I would agree. If you have restenosis, the first layer of metal, it's criminal to not image to know what's going on. And 3 layers of metal is bad. And the reason you get 3 layers of metal is because nobody imaged the first 2. And at that point, you start getting mechanical issues. So I think I don't care which stent, and I don't get so much into the radial strength issue. I think it's much better to do appropriate vessel prep and appropriate sizing in the long run. That's going to affect outcomes a lot more than which stent I put in.
David, with the provisional technique, do you, like Nordic has evaluated, Nordic 3 did a study of FKI and no FKI in one arm with the provisional stenting. And result was equally good, both were equally good. In fact, there was a problem with the FKI. As you said.
Just to clarify, so in that study, there was no difference in 6-month major adverse cardiac events, but side branch restenosis and TLR is lower with a final kissing balloon technique. And like I mentioned earlier, in the Korean COBIS registry, for example, their data would also support lower risks of side branch TLR with a final kissing balloon technique. I leverage both hemodynamic assessment and imaging in these cases. If especially if the imaging result is widely acceptable and we haven't compromised the minimal luminal area of the side branch, whether it's the LED or circumflex very much, then I leave it alone. If it's something where there is compromise, though, from a pre-stent, pre-crossover, then I'll go back and do it.
Absolutely. Wherever there is a TIMI3 flow compromise, then only you can consider the FKI. Otherwise, no. That's what you are saying?
No, it's not just about a flow issue. If by imaging I've really compromised the minimal luminal area, even though, and again, this is strictly personal practice, but I'll tell you, we all sit up on boards and panels at meetings of left main, and we all look around and nod that we do the same thing. So if there's a real compromise of the minimal luminal area, even independent of the FFR, I think a lot of us will be motivated to go back and treat it. And I think we'll get more data from EVC main about this too.
What about the wiring? Do you prefer, what kind of wiring? Distal strut wiring or proximal strut wiring in various types of technique that we use, especially in double two stent strategy, rewiring?
Well, for as I mentioned in my presentation, this whole concept of wiring in the distal part versus proximal part of the side branch you know, it's easier said than done. Most of us are just happy we get the damn wire down the side and a balloon crosses over and lets us do it. So that's the first very important disclaimer here. But in theory, at least, if it's a DK crush technique, you want to come more proximal into the side branch so that you can re-expand that initially placed stent. If it's a provisional technique, to go distal so that you get adequate coronal coverage.
Is there a difference in rewiring in decay crush and other techniques? And what is that difference that you are unable to rewire the side branch?
Well, I just, you know, as I just referenced about the initial rewiring for the second kissing balloon inflation, but I think that after performing the initial first kiss of the double kiss crush technique, certainly that is, at least in my experience, a much easier side branch to recross with a guide wire for final completion after the second stent compared with other techniques, because you've already facilitated re-entry into the side branch with the first kiss.
Is there any percentage of cases where you are unable to cross the side branch with the mini crush or any other technique for that matter? So those cases will come back with the ISR more often, and that's why decay crush has the best result. We can argue that rationally in scientific manner.
Yeah, it's pretty uncommon that we can't recross. It's really more an issue of how well we're willing to try, and with what guide wires as well.
It is reported that about 15% patient you can't recross the side branch. What is your experience, other operator? Any other panelist? Any different experience? Sunil?
So I unfortunately I do have to log off here at this hour, but I'll just say that I think that if you do adequate proximal optimization, I think your chances of crossing into the side branch are much, much higher. So again,
absolutely,
you know, to sort of echo what we've been saying, I think there's a process that has to be followed, and it's important not to take shortcuts.
How about the elliptical deformation that occurs after the FKI? And that is also corrected by POT. But POT has to be in the proper area with a second POT, final POT, what we call, has to be in the proper area. David? One or two final questions.
Using the POT technique to avoid side branch distortion, is that correct?
Yes.
Yeah, I think certainly, as Sunil mentioned, the POT technique helps expand the stent. It helps side branch reentry. Does it necessarily change whether you're going to have to go back and salvage the side branch with a balloon inflation or stent? I'm not so sure about that.
Okay. Anybody has any view on this, Bill?
I think a lot of, if you look at the data, the ovoid tends to be in the circumflex, and I'm not sure that's because of the way the balloons and things are. I think it has just more to do with the anatomy of the ostium of the circumflex. And again, that's why I tend to make that my main branch and the LAD the daughter. And if you do that, you see a lot less of this ovoid structure because you get better stent expansion, making the ostium of the circ the main branch.
Absolutely. And then there are questions, when do you use protected PCI in left main?
For me, for the most part, it's more to do with the hemodynamics. So we right heart. So it's I don't do it in people with normal LV function, but if you have low EF, especially, under 40, we would do a right heart catheterization. If the wedge is over 20, if the PA sat is under 60, and their blood pressure is low, that's someone who's more hemodynamically tenuous, then I'm more likely to use support. The other is, it depends on how long I think I'm going to make the left main ischemic, like the patient that I was doing where I was planning to do IVL. IVL requires that you be up for a while to do it properly. And that's, again, a lot of bad left main technique is because people are rushing, not doing the right thing. So if I think I'm going to be up for a long time and cause prolonged ischemia, I'll be more likely to use support to allow me to do the job well the first time.
Okay, the very interesting discussion that we have. And any other point, anybody, any of the panelists would like to say or bring out, and then we can conclude, I believe.
Vijay, thanks for having me. I've got to run to the hospital, as I mentioned
Okay.
at the beginning. So good to see you all, and thanks for the program.
Thank you very much. I would like to clap for all of you for a good deliberation on left main PCI intricacies. Every one of you, all the panelists, thank you very much. Thank you, Bill. Thank you, David, Julio, and also Sunil. Thank you very much.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Bye, William.